Matt, great to see you. Thanks so much for coming on and sharing a little bit about your experiences and what you've been up to. I'm excited to have you share about what you've been doing and some of the great things and information you know. So thanks so much for coming on.
Yeah, thanks for having me. I appreciate it.
Well, for all of you that maybe don't know yet or haven't read all about Matt yet, I'm going to give him a little bit of an intro here. So, Matt Klein is a DPT or PT by background, and he's got a specialization in orthopedics and geriatrics. He's also a fellow of the American Academy of Orthopedic Manual Physical Therapy. He's a core faculty member at West Coast University in their Department of Physical Therapy, and he is en route to gain his PhD right now. And so, Matt, thanks so much for coming on. We appreciate it. Do you have anything you want to share a little bit about yourself or anything you want to add to that?
Yeah, I think my only other thing that most people are going to know me online for is being the founder and chief editor of Doctors of Running, which is a website that has gone beyond all my expectations of something I started in PT school to help kind of translate what footwear was for people, because I worked in the running industry for many years before and during PT school, and was kind of a little, no offense to the marketers, a little annoyed that a lot of what was said wasn't exactly matching how the footwear was. And as someone who is who used to have very sensitive feet, I was like, I really want to help translate this. So it started off as a website, an educational website, and now has blown up into this huge shoe review, running, biomechanics, still core of like trying to help people understand what they're putting on their feet, but understanding there's an art and science behind that, which is our tagline. And I can't help but saying that. But yeah, that's probably how most people know me, is through Doctors of Running, and
I
also
am so
explains my background too, if people can see it.
I am so glad that you shared that because I'd much rather you share it. And I'm
Yeah.
gonna have to brag about you a little bit more, Matt. I gotta read some of these times here. 3K 853, 5K 1445, 8K 2451, 10K 3136, half marathon 1 hour 11 minutes, marathon 2 hours 32 minutes. Whew, that is fast.
Yeah, I appreciate that. I don't have much of that anymore, thanks to a PhD, working a lot, and trying to become a professor. And now a kid. My kid is how many days? 15 days old. But yeah, I will tell you, from somebody who was not fast, didn't really run in high school outside of running on his own, that if you train smart and you train hard, there's really nothing you can't do. And a lot of that was just my own post-collegiate stuff, trying things and seeing where I could get. Some of it was collegiate, but yeah, went to D3, University of Puget Sound, which was a phenomenal and fun place to go to, especially I'm from the Northwest, so I miss the rain being in Southern California right now. But yeah, there is really no limit to what you can do if you're willing to put the time and the work in. So I was very fortunate to have some cool experiences with that.
Well, Matt, I want to
Yeah.
get all into some of your work with Doctors of Running,
Mhm.
but I want to take you back a little bit first. Tell me, what led you to becoming a physical therapist in the first place?
Yeah, it's a good question. So I have been a hyperactive kid. I'm the classic, like, diagnosed with ADHD, but I'm going to argue, based on my own research and the many, many wonderful psychologists and psychiatrists I've treated over the years, and discussing this with, was it really that, or was just a kid with a lot of energy? That's another discussion in the mental health and diagnosis world. But yeah, very hyperactive, loved moving, loved trying to see how I could move in the world around me. And I had two parents in the healthcare field. And so I've been in healthcare since I was a little kid, watching things. I think a traumatic story that I don't really remember, my mother tells all the time, was taking me with her to see a patient, and the patient died with me in the room. And I was like, oh, okay. So that kind of tells you where I've been from a young age. So I observed a lot of stuff, and all power to our surgeons out there, but I observed a lot of situations where surgery didn't have the effects that were always intended. In high school, I was working at OHSU doing research and looking at the gut biome and what happens with surgery. What we discovered is that surgery doesn't just disrupt, you as a human being; it disrupts the other beings within you. And that is actually where a lot of complications can occur, is not at the surgical site, but is at the gut biome being so disrupted that can throw off all kinds of things. That's a whole different conversation, but is funny that I did that. And now, as someone who studies one of the many things, chronic pain, and realizing that your gut is the second largest source of neurons in the body, it was kind of like, I wonder if there's another way, because I really want to do healthcare. I don't want to be cutting into people and causing this. But I'm sure some people are going to need to. I don't want to do that. So that's when I discovered PT, because I was your chronically injured runner who was a late start, didn't start cross country and tracks until my senior year, and got injured both seasons with IT band problems. Nobody was able to really figure it out. I was getting taken to massage therapists, sports physicians, and they'd be like, "Oh, you have IT band problems." I'm like, "That's cool. What do I do about it?" And it wasn't until I saw a PT who's like, did analysis, like, you have some glute med problems. If you can get this kicking on, that's probably going to help. And within like 24 hours, I was already able to run for the first time in weeks. And I'm like, that was cool. She treated with movement. That was so cool. And I just knew immediately that's what I wanted to do. So went through college, applied, got into Western University of Health Sciences for PT school, and then have not stopped since then. So yeah, it's been something I'm very passionate about, treating with movement, helping people move better.
Man, we have a similar story, not only from being younger fathers, but also from the standpoint of having parents in healthcare. Tell me, because one of my first experiences with a physical therapist was early on, and it was associated with a sports related injury myself. And I ask you, how did that first movement assessment, running gait analysis, if it was that, how did you perceive that as a consumer of the product?
I thought it was cool because the first thing, as someone who's healthcare, like a lot of your visits are super short, right? You have like 5 minutes. It's super quick. You don't really know what happened. This person spent 45 minutes with me and just went through, hey, how'd this happen? Talk me through this. I wish I remembered her name. It was at Providence Milwaukee Hospital in Oregon. And she just took so much time and explained what was going on. It was so thorough. And I was like, this is so cool. Like, I didn't understand at that point in high school that there was that many components to the body, that many different movements, that many things that contributed, and all these different pieces. And it was cool to watch her as someone who likes to problem solve, like kind of go, okay, not this, not this, not this, check, 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 check. But what was also really cool about her is that she got right to the point. I had seen other PTs who were like, oh, I give you these same 10 exercises every time. And it was kind of like, I remember having an experience when I was volunteering before I got treated going, you gave 10 exercises and the person only did one. The person's like, yeah, that's fine. It's like, isn't that like a 10%, like grade wise? That's terrible. But this person, when she was treating me, went, I'm just going to give you one. I'm going to tell you what's going on. And then I'm going to give you the one thing that you need to work on. And you can just like, it was for free. It was just because I was there volunteering and she was nice enough to do this for me. And I just blew my mind as a consumer going, that is so cool. Like, you didn't make this complicated. You got right to the point. You explained it on my level. And you gave me just the one thing I need to work on, which is exactly the same how I treat today. It's like, I'm not going to give you like 40 exercises. What's the primary? That's why I did all this extra training. What's the primary impairment? What do you need to be treating? And how do you keep moving on with whatever you want to do? It was really cool. And she was so kind and empathetic. And it just struck me as like, I really want to do this. This is cool.
So then let's fast forward a little bit. You had that wonderful experience with that PT, and you got that power of exercise, which I agree is so powerful. Mm-hmm. Tell me, so you went through PT school, you graduated, and then you kind of said, okay, I got my degree. What do I do now? Tell me a little bit, what'd you do right after you graduated?
Oh, I knew exactly what I wanted to do, is basically taking this as far as I could. So I was the crazy one that did orthopedic residency at Casa Clina, which was a great and very difficult experience. It was also very challenging because I was an ortho guy, and for those who don't know, in Southern California, it's a phenomenal neuro rehab facility. So whether I liked it or not, I was getting tons of neuro stuff, and I was like, I don't know what to do with this. But it was a very great experience, got challenged quite a bit. I then went immediately into the Kaiser Sport and Rehab Fellowship, because I already knew I wanted to do residency fellowship and take it as far as I could, because I did know I wanted to teach. So I figured, if I'm going to teach and I want to make myself valuable, why would I not go as far as possible to try to inspire other people, which has probably gone a little farther than I maybe, like, I don't know how to say this, like normal, like psychologically normal is my wife. Like, I'm always like, oh, can I do this fellowship? My wife's like, please stop. Like, I let you do residency fellowship and now you're doing a PhD. Like, can you just be a normal human being? Which is not how I operate. But yeah, just residency fellowship, which was also so hard, but such a good experience. And then obviously within a couple months, as I finished that, jumped into the PhD program at APU. So, and that's where I am right now. So still haven't really stopped.
Yeah,
Yeah.
tell me a little bit about the PhD program. By the way, I love the comments about, taking it as far as you can. I love it how, it seems like a pretty much constant pull with your wife. That sounds
Yeah, as someone who's much more stable, like not stable is right, we're much more level-headed than I am, where I just want to like, can I do this? Can I do this? The PhD program, for those who don't know, for any PT students out there that are interested, if you want a full-time faculty position for sure, at this point, you need to get a secondary doctorate degree. And I didn't know that. So I thought if I just did residency fellowship, I would make myself valuable enough to get a teaching position. That did not work. Especially if you're in Southern California, where there's already a lot of PTs down here and a lot of other people with similar goals. And if you don't have the right contacts to university, it's very challenging. So I, as soon as I finished, realized, okay, if I really want this teaching position, I got to do this PhD. So I was looking at USC's PhD program, and I know Chris Powers, and I knew APU was opening up a program. So I'm part of the first cohort. So I remember talking to him and going, hey, Chris, like I just did a residency and fellowship. Clinical practice is really important to me. You know, based on what I'm looking for, I really want to teach. What do you think? And he goes, you should do APU, because if you come to USC, you're going to be a lab rat. This is his words. He goes, you're not going to have time to practice clinically. That's just the way it goes. And I was like, I can't lose these skills that I've been working on. And APU was a bigger draw because of the faculty. So Annette Kareem, Derek Swecki, all these people I looked up to for years. It was a huge draw. And so I jumped in there initially going, I'm just going to get this done to teach. And it totally reversed, where the more I did this, the more I was jumping into biomechanics literature and studying the stuff like, oh, this is actually pretty cool. Like, this is super hard. I don't know if I would suggest this for everyone. But it's taken me really cool places. So I just published a systematic review on masters runners, which is where my area of interest is, masters runners and Achilles tendinopathy with a small background in chronic pain. So to get published and to go through these processes was a very good experience, especially because it's not just the teaching at this point, it's also wanting to contribute. So it was a very good experience, just not a short process. And I definitely tried to rush it. And got what's the term? Life it was like, I'm gonna humble you. And it wasn't that I was arrogant. I was like, I can get this done. They're like, no, it's gonna take you 4 to 5 years, and that's 5 to 6 years is the average. And it's been a good experience because I've been able to practice. And then even before I was done, I was able to get a full-time teaching position. So it's been a great experience, and it's challenging me more than I ever thought. And yeah, my wife was like, please don't do this again. But I've definitely looked into other programs after. But I have to balance having the kid is now my new tertiary doctorate program, which is I know nothing about, and has been a reminder of how little I know every day. So,
oh boy.
Yeah.
Um, I can comment on that one too.
Yeah.
When it comes to some of that reason, what
Yeah.
led you to some of that reason? Masters runners, and for those of you in the running world, I'm sure familiar with, but masters runners meaning folks that are not fresh out of college, not on the younger side, people that are on a little bit the older side. Please correct me if I'm wrong.
No, that's very true. And I think the United States Track and Field Association used to redefine this, because they define it as anybody over the age of 35 to 40 competing. And I would really argue is we're seeing many Olympians in that same age range. From my research, what I've seen is a lot of the age-related changes they start at 30, but they don't really start until 50, and then they really accelerate at 75. So if you talk to people, they're like, yeah, I can still compete pretty well in my 40s, and then 50 hit me, and I'm like, what happened? And that's because you do start seeing a little bit of that acceleration. So for my stuff, I argue it's 45 to 50 and over, but United States Track and Field says that's a little different. But I was interested because that's a lot. So I'm both an orthopedic clinical specialist and a geriatric clinical specialist. I love ortho sports, but I also love working with older individuals with a variety of things because it's so interesting. I hope this doesn't come off as mean, but a lot of times in sports, it's kind of the same thing. And you're like, oh yeah, you're 25, you're 30, like you're healthy, you can do all this. That's cool. But give me someone who's 60, 70, 80, who they have all these comorbidities, and you've still got to figure out how to get them through this. And you add the psychological component of age-related changes and just the experiences of what happens. That's so fun. It's like, wow, this takes so much creativity. So I really like that. But also slightly self-serving. We're all getting older, and I'm like, all right, so if I want to keep doing this, and running. How am I going to keep doing that? What are the injuries that happen to us? Can we start like working ahead on this stuff? So and that's also the major patient population. So I still treat a lot of people privately down here. And masters runners are kind of my favorite group because like, all right, you got age-related changes. In Southern California, especially, you've still got people running sub 15 over 50 and doing some crazy stuff. And I'm like, how are you doing that? How do we keep you healthy? And how are you doing at the same point? So that was my interest. And I will have to admit, so it's focused on Achilles tendinopathy, which is the most common injury that master runners tend to experience. They experience all kinds of things, which one of the worst parts of my study was like, you have to be healthy for at least 12 months, except for if you've got Achilles issues, which is really hard to find master runners that have been healthy for 12 months, just because that's what happens, right? But yeah, it's interest of like, all right, we're getting older. This is who we treat. This group needs more attention because there's barely any research on them. A lot of them either get stuck into, yeah, you're still 25, or as I've experienced and watched, because I did a qualitative analysis on some of this group, and they're like, yeah, like one patient that I got to work with, and then ended up, she was part of the study I didn't publish, but she almost set the age group US record in the 5K. And that she did this, she's in her mid 60s. And the next day on Monday, she went back and she had to go get a physical from her primary care. And her primary care was like, why aren't you using a walker? Why are you still running? And she was like, excuse me? Like, I'm running at like US record pace and I'm training. I'm hobbling because I am sore. And I train 50 to 60 miles a week every week. And I haven't been injured. I don't know. And so I've just heard this story so many times and going, wow, it's because people don't understand being highly active into older ages. And I think we need to normalize that. So sorry, that went super long, but that distilled it down to like the core of why I'm doing this is because older people can be highly active. It's that group over 50 is the greatest, the group that's expanding the most among all marathons and races in the country. We are seeing that group participate more than any other age range. And yet they're still being stereotyped as, oh, you should get a walker. Why are you still doing this? Instead of going, how do we support your body to be able to do this? What does the literature actually say? And what little stuff out there says, move or die is basically what it comes down to. Like, you need to figure out how to keep moving. And if you can move at a high level, do it as long as you possibly can, if forever. So that's where the PhD took me. And that's why I still do this and will continue to research this stuff afterwards, because it comes down to looking at a group that's been marginalized and stereotyped. And I hate that. And I would never want that to be done to me. So why not put some stuff out there?
Yeah, Matt, I absolutely love that. And that's actually something we hear from course attendees quite often, is especially in the Essentials of Running Gait Analysis course. We'll hear them talk about, hey, I got this runner that they are, maybe on the quote unquote older side, maybe, 50, 55, somewhere in there. Older in terms of, some people think that's too old to be running. And sometimes what we'll hear is people talk about, well, what can I do to help get this runner better? What can I do? What are some of the things that can keep this runner running? I can personally tell you from the amount of research I've done, finding those people you can actually use and say, this correlates to what I'm looking for and gives me an unadulterated view of actually what I'm trying to study, is so hard. So I guess a little bit pulling from your research, a little bit pulling from your personal clinical experiences, and in general, what do you think are some clinical pearls you could give clinicians about those runners that are maybe 50, 55, 60, 65, 70 that could help them run?
I think the biggest experience, the best experience, is go to a race and get your butt kicked by one of them. And that's a great experience. Off topic, when I first came down, Southern California is some of the fastest masters runners in the country. So when I came here, I was a, pretty decently fast, post-college kid and still running low 15s. And trust me, when you're 23 and you get out-leaned by a 54-year-old who's dealt like 54, 56-year-old, Pete McGill beat me in a race. And for those who know Pete, he's phenomenal. He's insanely fast. John Gardner, who's another really awesome masters runner, beat me in another race, out-leaned me. And I was like, so again, don't stereotype. Realize the human body is so much more capable than what we give it credit for. And I would say 50s, 60s is still not old based on what I'm experiencing. That said, what does change as we get older is we start losing muscle mass, we start losing more strength than we lose muscle mass, and we start losing more power than we lose strength. So running is great for maintaining endurance, for maintaining your mental health, for maintaining a lot of factors, physiological factors. It doesn't really help with your strength. So the biggest thing is if you look at something, yes, there are age-related changes. You're welcome to look at my systematic review that really summarizes that well. But one of the key things is making sure this runner is not only is strong enough, but can handle the forces associated with running. Because again, if you don't strength train, you don't tend to maintain that strength as well. And we've seen that. So making sure you've got the ability to generate force and make sure you've got the ability to generate force quickly is really important, because those two things we're losing, but they're also really important for running, but running doesn't do a good job of maintaining them. So those are kind of two things. Outside of that, it's your classic, like, do you have the right mobility? Do you have the right coordination? But the strength and power component is insanely important, which most people don't expect me to say, but I literally say the same thing for anybody in the geriatric world, that power and strength are so important. If we had more people that were powerlifting and strength training, our population would look so different. Especially, it's for masters runners. Not only is it like, if you can encourage them to go, I know you don't want to do this because you just want to run and that's all you want to do, just like all runners. But if you can just do like 2 or 3 things a couple times a week, you can make such big changes. And it's one of the few things that will not only treat a lot of these things, but also it can prevent injuries, right? It's one of the few things outside of switching shoe, like having a variety of shoes, that we know actually decreases. So for the older runner, it's not that different from the younger runner, except remembering that they are losing strength at an accelerated rate because of those changes. So pay attention to those things.
Yeah.
And there's no age that you stop the ability to gain strength or handle these functional activities. So talking about longevity and going, this is not only going to help you now, but this will help you when you're doing this when you're 90, which I have a patient who's 92 and still runs up and around Mount Baldy and Mount Wilson here. So, 50s, 60s is you're still like elementary school. Come on, let's go.
I might say, it goes far to say, that might be personal goals for me. And
yeah, exactly. Right.
Yeah, I love that. And probably one thing you're commenting on is, it's one thing to be able to do a single leg squat, but being able to do a single leg squat with weight or with resistance or under load is a lot different, especially if you're going to be running down hills or potentially, trail running or even just flat running. Those forces, especially at speed, whatever speed you're running at, it's going to take a lot of strength. And so maybe some examples you're talking about are some single leg squats under load, maybe some resisted, even a leg press, maybe some hip abduction. What are some of the other things you notice are kind of stuff you love to give, if you could share?
Yeah, you bring up a great point that I want to emphasize this for listeners, both PTs and non-PTs, that a body weight exercise is great, but if you do not add external load or make it challenging, you're not going to see some of the changes that you really want. So yeah, it's really simple. And honestly, I'm the person who, I don't like set exercises. I like figuring out what the impairment is and then doing something that's really unique for that person. That said, based on some of the changes, like single leg hops are really important. I will tell you, for the little peek behind the curtain of where my research is right now, single leg hopping for masters runners, except for a couple of them, is really hard because it requires that power. It requires both the power generation as well as the power absorption when you land. And it's a simple exercise, but it's very effective. Weighted single leg stuff is great. If you don't have the balance, weighted something squat, something deadlift, whatever it is, grab something that's a little bit heavier, lift it a couple times a week. It doesn't have to be complicated. It just has to be kind of something the person's willing to do. And that's why a lot of times, so my classic ones that I'll give people is, hey, what do you do every day? Oh, you brush your teeth? All right. Can I bother you to buy this kettlebell, put it in your bathroom, and you're going to do single leg heel raises when you're brushing your teeth with this 30-pound kettlebell? And they're like, what? And then it's integrated. It's part of their day. So I'm that person where I like to turn, just like how I started, I like to turn whatever their day is into an exercise. So sit to stands, calf raises, single leg squats where they're at the kitchen sink or cooking, right? So dual tasking is really important.
And I love your comments on not only making it functional,
Yeah,
but pairing it with the actual gait deviations, impairments, kind of whatever you want to call them, what you are
right,
seeing as a clinician, both on a running gait analysis and potentially in their objective exam
right,
or whatever, kind of functional movement analysis you
right,
are doing, is so important. And I can only speak for me, but me personally, I loved being able to say, okay, look, we have valgus collapse of the knee. Okay,
right,
great. Well, what are we going to actually do about that? Well, we can strengthen quadriceps and hip abductors all day
mm-hmm.
long, but we really want to make sure you're doing it in this position because this is the same way you're running. You're running
Right,
in this style. Let's mimic that position and then give you something that can actually help engage that muscle.
right. And it's
And that's
so
what
much
I
more
think.
fun to treat impairment, right? Instead of going, I give this exercise no matter what person comes in, going, let's dive in there and be the clinicians to go, all right, what do we do for you? That makes it so much more fun. Like find the like, yeah, there's no magic exercise. Find the impairment, treat it, make it a little more functional eventually, make it a little bit more harder, a little harder, and then they're usually gonna be fine.
Um, on that same note,
Yeah.
Matt, when you do see impairments or when you say, hey, there's a gait re-education technique I want to use,
Mm.
or maybe they're adjusting to a pair of shoes, how do you balance that strength training and strengthening with some of the coordination form, if we want to call it, kind of change of
Mm-hmm.
technique, if we want to call it that? How do you pair those things off each other? Because I love what you're saying. Do
Yeah.
this one thing while you're brushing your teeth. I love that. But kind of
Yeah.
how do you intermix those things in so people actually carry through with it?
That's a very good question. So there are some maintenance things or some loading things that I will certainly do for people, and this gets easier for the super motivated person. It's like, oh, I'm going to do this like every single day. But it's like, okay, but some of the best changes you can do, if possible, is going, hey, what little cue could I give you while you're running, right? Because the one thing that people are going to do over and over and over again as soon as they can is run. Is there a small cue? As little as possible, because the bigger cue you give, the more likely it is to really mess with their mechanics. And you want this to feel good, right? Making movement changes takes time. Like form changes are something I try to really hold off on because it takes so much time to make those motor changes and for people to actually turn something from a skill like this practice skill into a habit. Like everybody got super excited with all the like forefoot heel changes, all that stuff. If you look at the evidence, it can take anywhere from 6 to 9 months to make a change. And I rather use the muscle physiological stuff, like the 4 to 6 week changes are a lot quicker. But that's where trying to see, hey, can I train you while you run to start making some of these changes? And that might be make a conversation going, hey, you're used to doing a hard workout as you're recovering. Can your hard workout be, can you focus on trying to make this little change, right? Are you okay doing a run inside on a treadmill in front of a mirror so you can get some biofeedback, right? Though it's being creative with what the person's willing to do. So there's no set thing. It's like, how do I get this into it's my common theme. How do I get this into your life with being as minimally invasive as possible? And what people don't realize is when you're doing this, I'm like racking my brain trying to be like, what are all the motor control concepts again and motor learning? Like, how do we integrate this? How do we add dual tasking in and all this kind of stuff and make it not look like it's crazy like it is? But like for you and I going, oh my gosh, like they're doing like 4 things at once. Like talk about it's like simple, try to integrate it. But the practice, that's what it all comes. If you look at all the motor learning research, is you just got to get them to somehow practice over and over and over again. What that'll look like for each person will be different, but the easier it is to do, the more likely they're going to do it.
Which kind of leads into exactly my next question for you. And
Yeah.
then I do want to kind of get your thoughts on some footwear as
Yeah.
well. But as
It's not
we
like that's my whole background or anything, it's fine. I'm just kidding.
no, not
Yeah,
at
no,
all.
it's fine.
Um, as we look at some of those techniques, it's so easy
Mhm.
to look at a patient or a runner and go, oh my gosh, I want to change everything. I want to change your footwear. I want to change the way you're running. I want to change all these corrective exercises. You've got an hour's worth of things to do. Plus, we're going to just totally overhaul what you're doing. And not only do we see that the carry through with that is low, but we also
Yep.
see that it can actually cause more chance for injury.
Yeah.
How do you feel about integrating cadence into the changes people are making, runners are making while they run?
That's a great question. That will determine, as you just talked about, going, hey, like we're throwing lots of stuff at them. I am very fortunate the residency and fellowship I did really hounded us on what is the primary impairment. And the little background on this is if anybody has been a PT for Kaiser, you know that you do a lot of evals and you may not get to see that eval for another 2-3 weeks if you're lucky. So you better make sure you hit exactly the most important thing and give them the 1 or 2 things necessary to make sure they can do that in case they never see you again. Because loss to follow-up happens, right? If you're having to wait 2 to 3 weeks to get back in, or even longer sometimes because of the volume of patients you see, it happens. So you get really good at that. You have to realize what cadence is doing and what you're asking somebody to do with that. So cadence can be good, right? We do know that it modifies some of the impact forces. We know it changes some of the work that's happening, where a lot of the forces are happening. It just depends on, is that actually the source of the problem, right? So you have options. You can increase somebody's cadence, right? And then with each footstep, you're going to have less force with each impact. But you have to ask yourself, is it because they're landing too hard? Or is it because when they're landing, their muscles cannot handle that level of force? So you got to decide which is the bigger problem. Because if you say, yeah, they're strong enough, they're just slamming down too hard, and a little cadence stuff would change the overstride, would change some of the impact forces, great. But if the primary impairment is you need to work on your strength, I'm going to focus more on, I'm going to give you some strengthening stuff to really load you up so you can handle that kind of stuff. So I know all the students, and you know this just as well, hate the phrase, it depends, but it really, really depends on the person and their primary impairment, whether it's a movement issue and I want to change an overstride, or if it's, yeah, you just need to work on strength and ability to shock absorb.
Yeah. Yeah. Matt, I want to change gears a little bit and kind of go back to your journey just a little bit. You know, as a runner, as someone that had experienced PT firsthand, and then even more so as someone that was in physical therapy school and you knew you wanted to take this as far as you could. Didn't quite predict that PhD might be on the horizon, but you know, life is full of surprises.
Yeah.
You start Doctors of Running,
Mm-hmm.
and as you kind of mentioned, it kind of took off. Tell me about a little bit why you started it, the inspiration, and you know, where do you see it going?
That last part, I have no idea at this point. It's beyond all expectations. I will do my best to answer that. But like I said, it started in PT school because I had been working in running stores all throughout college. And I'm very lucky to have grown up in Portland, Oregon, which is a huge shoe mecca for those who don't know. Currently, Nike's there, Adidas is there. Mizuno used to have a research lab. Mizuno, please don't get mad at me for saying that. I know it's a little secret. Under Armour's division is there. Hoka's there right now. On is there. Columbia's there. And there's a bunch of other footwear companies that actually have research centers and areas there. So I got to meet people and learn things because I was super curious and obnoxious and asked questions all the time. And learned all this footwear stuff because I was very curious. I'm like, what am I putting on my feet? Why does this not feel good? Why does this feel good? Like, why are they doing this? Why is this shoe curved here? Why is it? What's the fit like? So I was very lucky to pick all that stuff up. And then as I kind of progressed through college, I was learning more. I was like, well, I want to go to PT school. And then in PT school, there's 2 reasons. The noble one was, yes, I want to share this knowledge with people. This is really frustrating to go through and not know, like, what am I putting on my feet? How can I make this easier for people? As someone, when I was working in running stores, I did not try to sell people stuff. I was not paid on commission. I was paid per hour. So I'm like, I'm going to show you exactly what you need, nothing more, and try to make this as simple as possible and exactly what you need. So it was educational, right? I like teaching. The second thing was I was a runner running 100 plus miles a week, and shoes don't last very long when you're running 100 miles a week. And I wanted free stuff. Because I looked at people like Pete Larson, who had Run Blogger, and I'm like, what? He gets sent shoes for free? That's awesome. How do I get that? Because like, once you go far enough out of the running industry, there's only so much you can bother all the tech reps to get like free stuff. And they're like, yeah, aren't you been out a while? And I was like, oh. So yeah, it was, I kind of wanted free shoes, which didn't happen for a long time. Like 2 or 3 years in, I was still doing reviews and buying my own stuff. And then Skechers actually was the first one to go, hey, we liked your review. Can we send you some stuff? And literally the day before, I was like, I should quit this. This is stupid. It's never going to happen. Which, by the way, every time I have that thought, usually something happens. So I should maybe keep being negative, despite what my wife tells me to be more positive. I'm just kidding. But yeah, it's then Skechers started sending stuff. A couple years later, I met Nathan, who is a phenomenal human being and runner, during fellowship. And I was like, hey, I'm doing this thing. Like, you want to help me with it? And he's like, yeah. And then David, who actually was a couple years below me in PT school, we brought him on, and we just, this cool group that just started throwing stuff out there. Like, they were willing to follow me on this journey of education and sharing stuff. We started to put stuff out there, and all of a sudden, like, Mizuno reached out, Saucony reached out, and then it just went from like, what is this to like, it just took off. And I'm really thankful because it's been cool. Like, a couple weeks ago, I got to talk to a CEO. I can't mention exactly who this is. The CEO of a major worldwide running brand was like, can I talk to you for an hour and pick your brain about how you think our product is doing in the United States, and why it might be, different from another major company out there. And it was such a cool experience to pick the brain of this individual that's had all this experience in the marketing sector. And I come from a very different biomechanics section, to just get to know people and go, yeah, the running industry is made of people. It's not this magic machine, right? And so you'll hear like, oh, they're just out to sell product, or, if you're a minimalist person, they're trying to ruin your feet. No, it's just a bunch of people trying to make product and put some cool stuff on the market. And they all run in each other's stuff all the time. And they're all footwear geeks. And so it's been a really cool process to get to know people and then keep learning. Like, every time we have a conversation, every time I have a guest on the podcast, or we go somewhere, it's just such a cool experience to learn and have things challenged. Like, I got to go to Brooks in Seattle at the beginning of the year. I guess I can say this now because they are debuting the shoe, but they were debuting the Ghost Max. And I got to meet their whole biomechanics team, and a bunch of them have PhDs. And I'm like, hey, I'm like trying to finish this PhD. Like, what do you think? Like, keep going. It's okay. But just to pick their brain and kind of understand like all these additional geometrical things that they were doing to the midsole, going, oh my gosh, that influences the moment here. It influences how the sole collapsed. Like, I totally learned all this new stuff. So the purpose, what it's evolved into, is we get so many shoes now that it's obscene. So I don't have to worry about that. And I try to find anybody with size 10 that I can give stuff to, because this fills up really quick. But it's become this journey of teaching people, trying to make this simple and help them just be able to enjoy their run. Because this takes a lot of effort to think about and going, what am I putting on my feet? Like, does it feel good? Is it right for me? It's like, let's just simplify this, keep learning, but how do we make things better and more straightforward so people can really enjoy their run? So going forward, we're hoping to be a little bit more involved in what that looks like. I don't know, with kind of continuing to help develop stuff. We don't charge companies. We do this as a side. We all have full-time jobs because we get plenty of gear, obviously, but it's fun to have an influence on what's being developed and not only teach within the industry and have people listen to our podcast and contact us, but also to learn back. So to continue to have this symbiotic relationship moving forward is really the goal at this point.
Oh, that's amazing. With some of those reviews and some of the information that is out there, how do you take some of it and make a more educated, I don't want to say review or analysis, but how do you kind of take some of the information, especially with some of the stuff that might not be as tested? Like, there's some good research out there that midsole firmness helps with plantar fasciitis, for example.
Right.
But some of the things may be less studied, like some of the energy return stuff, or some of the stuff that is and you probably gonna know this better than me, but some of the stuff that's out there that hasn't been as tested. How do you kind of go through and make that analysis, that review, that kind of construct that with the information that's out there?
Yeah, it's like doing a PhD where you're kind of foraging in the dark and you don't know where you're going and you hope you get something. No, I'm just kidding. But kind of, actually, it's best guesses. It's using, all right, here's the evidence we do have right now. Here's clinical evidence, clinical experience, right? Which is testimonial. And we always say, hey, you got to be a little careful with this. But it's making the best guess possible, because the research is never going to be at the same place the footwear industry or any area is. Like, the research is usually like 5+ years behind, if not more. So it's going, all right, how do we clinically reason our way through this? We know this person has X, Y, and Z. We also know this footwear is having X, Y, and Z. We have some evidence that this component to the shoe might influence your mechanics. So this might be a good option for you, but there's also these other shoes that might do well, because we also know the most challenging thing is that footwear is so specific to and unique to each person, which is why I always hesitate. People are like, oh, what are the best shoes for this? I'm like, no, like tell me a little bit more about you, and then I can make some suggestions, but you still got to try it on, because I might be totally wrong. Even though I have all this experience, the human being is this other variable that can totally throw that stuff for a loop. So it comes back to, here's our best educated guess, and we need you to know that. And if you're willing to walk along and learn with us, that's what we're trying to do. But we're never going to go, this is the best shoe. This is the best shoe for this. This is the best shoe for this. Because secondly, that shoe is going to change in the next year, and it's not going to be the same thing. So we can't always say that. So it's a lot of fun, and it's never boring to go, how is this adapting? What's the current evidence, and what's our best guess? But at the end of the day, you as the individual, you got to go try this stuff out. And people don't like that sometimes, but
and it's a hard thing.
Yeah.
It's a hard thing to hear, not only as a runner, as a consumer, but also from the clinical side is, you know, I've struggled with experiences where I've said, hey, I would really like to see you try this shoe. And then folks come back and say, hey, I either loved it or I hated it, or, okay, you know, I didn't really feel anything different. And all of that is information to me.
Yeah.
So I'm going to ask you the impossible question with the hopes that you're going to give me an impossible answer.
All right.
And that would be, you know, you see patients, you see runners, you have a lot of plethora, not only of data from the research side, but also industry knowledge. And obviously, we see trends in the industry, like ASICs, for example, and where they're headed, Hoka's, Ultras. You know, those shoes have changed dramatically in the last 10 years, especially 10 years ago. You know, a lot of people were running ASICs. We see that changing. So to refine my question a little bit better, when you see a runner, do you notice that it's better to say, hey, I want you to try to look for shoes that hold these characteristics? Do you notice it's better to say, hey, here's 3 or 4 shoes that might be good for you to try, go try them on, see how they feel? Or do you notice it's the education of, hey, you know what, actually keep in the same shoe you're running, let me fix as much as I can. Okay, I just can't change this. And I want you to try to get a shoe that just has this one attribute that's a little different. I just want you in a little less cushion or a little less heel drop. That's a huge question. What are your thoughts on that?
All of it's correct. It just depends on the person, right? All those are great responses. It's not a black and white where it's like, oh, this is the thing I use every time. It's very, again, impairment specific. There are plenty of people, and I will say this to somebody who has done this, who will shoe jump. They've got some impairment. They've got some problem that's driving this injury, and they're jumping from shoe to shoe to shoe to fix it. And it's like, it's not the shoes, it's you, and you need to fix this, and you need to modify this, and no shoe is going to fix that for you. There's no shoe that is going to prevent injuries. This is something that I learned talking to Simon Bartold, who is a phenomenal podiatrist. He's beyond a podiatrist at this point. I don't know, he's a god of footwear, who used to be the head biomechanist for ASICS. Our conversation was, there's no shoe that's ever been found to reduce injuries, but a shoe can certainly influence or cause one. So you need to keep that in mind. So there are situations where plenty of people are trying to jump and find a shoe that's going to fix their problem. I'm really going to hesitate to make that suggestion. There are some pathologies though, I'm like, you know what? You might do better in this. But like you said, there's always that one person that's like, oh, this felt worse. And I'm like, okay, that's information. What about you? What didn't interact with the shoe? But I always remember that. So that's why I'm like, it's going to depend on the person. If somebody is shoe hopping, I'm like, stop it. Stick with the shoe that's comfortable, because we know that's the best thing for you, and fix these problems. If it's like, hey, there is some influence from the shoe, you might want to consider these components if they have the shoe knowledge and they have the background to go, oh, okay, I know I've been running enough that I kind of have some experience in the shoe world. I know my way around brown stuff, that this person tells me, hey, let me explain what a heel bevel is, or what a forefoot rocker is, or what a wider sole is, or a post or sidewalls. They'll go, okay, I know what to look for now. And then I'll take the reins from there, because once I have that piece, then I can figure out what I know works for me. The final group is, I don't know anything about running shoes, just tell me what to do. That's when you're like, okay, you're going to go try this, this, and this, but you're going to tell me what you feel in them and let me know how you responded to them. Just like when you give an intervention, just go, oh, here's this exercise, go do it. You go, please tell me how you're responding to it, because that's also data for me. And then I can also, if you don't respond, I can adapt because that's information. If you tell me, great, it's peace for me and it's peace for you. But the impossible answer is all of it's correct. It's person dependent on other factors of what the experience of the runner is and kind of what is driving their issue.
And I
Was
think
that an impossible answer? I chose answer E, which was all of the above that wasn't on the exam.
yes, you did. And if in doubt, go with all of the above.
Yeah, exactly.
That's going to cover all your bases.
Yeah. I would say, instead of saying all the above, make sure you know who the person is in front of you. That will give you all the information you need. If you could really read the person, understand that person, which is why if any of my students ever listen to this, I hammer the subjective exam, because you will know the majority, even like you'll know if you can listen well and you can integrate stuff and you can clinically reason, you'll know exactly what to do just by talking to people. You just confirm it with the physical exam.
I had a mentor that told me, listen to what patients are telling you. They're giving you the answers.
Yeah, they are.
Listen for them.
You just have to, that's all it is.
Yeah. Matt, I want to respect your time, but I do have a couple other questions for you. One thing that I actually was wondering is, especially as you talk about these different shoes, and we recently had a couple webinars where we had several clinical, academic, coaching, running experts do some analysis and kind of get different opinions. And one of the interesting things is that there's so many different opinions of how to treat and how to approach runners. And then we had another webinar where we talked about running shoe experts, and when it came to fitting the shoes and their process for fitting the shoes, what happens when someone goes into a running store? What happens when they leave maybe the clinic and they're in the wild, wild world of selecting a shoe for them? And one thing that we absolutely love, and I absolutely love, is hearing about, you've got to connect the biomechanics, correlate that to what's right for the patient or the runner. And so my question is, what are some of the major trends that you see? Overstriding, for example, there's research out there showing overstriding with a minimal heel drop is more prevalent, or, overstriding or ground reaction forces, more impact with some of these higher cushion shoes. I guess, without going into all the detail of every single runner you've ever seen, what are some of the common trends you see? High cushion shoes are connected to this, or maybe higher arches are connected to this, or midsoles. What are some of those clinical pearls that maybe you could share?
Yeah, I think this shows you a little bit where I started. I keep going back to this. There are certain components of the shoes that will change forces. On the whole, do they do the exact same thing for every person? No, sometimes it's the opposite. It's like medication or exercise, right? There's always going to be that small group that goes, why are you responding the opposite to this? But on the whole, the majority are going to respond in certain ways. So I know heel drop really depends, is very dynamic. We found that more and more, especially as we get softer midsoles. So that will totally depend on where the person lands and how they load the shoe. But we do know that lower drop shoes tend to shift more of the work to the foot and ankle. And especially on the Achilles tendon and calf, you need to have good calf strength. You need to have good foot and ankle strength. We know that higher drop shoes tend to take a little pressure off that area and requires more work from the knee and the hip. It's just how it goes, right? We know that shoes that have a taller stack height that are very rockered also do something similar, where they tend to shift more of the work away from the ankle and up toward the knee and the hip, which can be good and can be not good, depends on the person. We know that more minimal shoes require a lot more muscular work and a lot more impact at the foot and ankle, right? Tibia, that kind of stuff. So there are some general areas, and people will always respond. My favorite ones is the small group that actually have more Achilles problems with high drop shoes, but that's a whole different case study. But on the whole, that's some kind of clean things. We know that some people, when you put them in a minimal shoe, will land lighter. There's other people that will still do the exact same thing and land as hard. There are people that if you put them in a maximal shoe, it decreases some of the joint reaction, the joint reaction forces. And there's other people that actually land harder. So just because you have a taller shoe doesn't necessarily mean you have more protection if you land harder. But Lauren Maslow, who's a phenomenal researcher in footwear, has shown that, yes, higher stack height shoes do provide more protection and do, in some cases, can reduce some of the forces, and for certain groups, reduce injuries. We know that based on some of his evidence that people who run occasionally, a more minimal or lower shoe can actually be a good thing. It can actually be injury preventative. For people that run a lot and are high mileage, unless you're willing to take the time, a little more cushion might do you some good. There's some evidence suggests that might be a little more better, which makes sense, right? Pounding the ground more, maybe you might want a little bit more. There's also going to be some variation in that, but that's how it goes. We know that stability has been redefined, and hopefully I don't know if I can give credit to Doctors Running and myself for trying to help reimagine what that looks like, but we know that stability works really well for people that have a history of stability or stability rated problems. So posterior tibialis problems, Achilles tendon issues, things that are actually related to the rate of pronation. How much is a different story, but whether we know that can be helpful, but it only prevents injuries in that group. If you've never had a problem and if you pronate, I can't promise you that a shoe with arch support is going to help you, or an orthotic. We don't know. We just know that a history of that, you might want to consider a shoe that has some stability in some way, but it also doesn't mean you have to stay in that kind of shoe. We also know, based on the evidence, that prescribing shoes based on arch height doesn't work. Military studies have shown over and over again that prescribing stability based on arch height, it only takes into things statically. You have to watch how people move. If you watch how people move, then you have a better story, which means all those wet paper tests and Dr. Scholl's foot scanners, not reliable or valid at all. They sell great product. They sell product really well, but they're not accurate or valid. You need to watch somebody move for that kind of stuff. I'm trying to think what else. We don't know yet on whether training in super shoes is a good or a bad idea.
Yeah.
It's some people do really well. There's plenty of people who that's literally the only shoe they can run in. Other people, you might want to consider using this as a tool, because there is no such thing as a shoe that completely eliminates forces. It just shifts them around to different places, right? Like I was talking about, a more rocker shoe shifts forces away from the Achilles, right? Which that's why Achilles tendinopathy and tendonitis typically do very well in rocker shoes if the rocker lines up with your foot. If it doesn't, that's a different story. So it's going to be, there are some kind of trends there, but you have to be a little cautious about the little components to them. I'm trying to think where else I can take this. That's the biggest things I can think of off the top of my head. Oh, yeah, that you don't get rid of forces. You just change where they go. And please remember that even if you go, I'm going to run in a minimalist shoe now, and I'm going to be super barefoot, and I'm going to it's super healthy for me. It's like, well, if you land just as hard and you don't have the foot and ankle strength, the mobility and the coordination to do that, you're still going to get hurt. Just like if you're in a super tall max tech height shoe, if you don't have the hip and knee strength to handle that, where the forces are getting shifted up there, you might get hurt. You might not, but you might. Just know that these components of the shoe are shifting things around. It's not meant to fix your injury, because you need to figure out why did this happen in the first place, right? And treat that. But a shoe is a tool. It's a tool that you need to learn how to use too. And that's where some of these super shoes, they don't give you free energy. You have to learn how to use those as well. So please don't just be like, I'm just going to go do all my mileage in this shoe. There are some adaptations we're learning about right now that it might be good to have a variety of things. And that's the last piece I'm going to tell you, is that the only thing we found out in relation to shoes and injury risk is that if you have several different pairs that you rotate through, that's the only thing that decreases injury risk. That's it. We've looked at all kinds of other stuff across that, which shoe companies love. If you have a couple different pairs and you expose yourself to different things, that is more likely to keep you healthy than any specific shoe, unless you have a specific pathology that might work better with certain things.
Matt, that's so helpful. I mean, especially when we see trends among running shoe brands, and that's one thing we were recently talking about, obviously Hoka has been a game changer.
Right.
In the 2010s, it was the barefoot running revolution.
Right.
And certainly that kind of opened up the fact that there was different genres of different shoes that people might run in, and that we went from these barefoot shoes to then more max stack height, absorption, cushiony shoes. And it's so interesting. It's exciting to see where things might go in the future. It's exciting to see where things might lead.
Like it's okay to, like you said, it's okay to have a barefoot minimal issue like the zero I'm holding. It's okay to run on the Primix if you can handle it. I wish I had my Primix strung too. I'm actually really enjoying those. But yeah, you just variety is key in seeing what your body can handle, which people don't like that answer, but sorry, it depends. Like it's not as straightforward as we want. And yeah, there are all these really cool innovations coming out, but we don't have enough information yet on how exactly they're affecting you. But I can tell you it's the really fun part. Our injury rates haven't changed at all since the 60s, 70s. People are getting injured at the exact same rate. The types change, right? So now that people have kind of moved to the more maximal stuff, right? You're seeing a little bit more knee and hip kind of things, unless you're in something like a Vaporfly, which that instability in the heel can still piss people's Achilles tendons off. Yeah. When we were doing the minimalist stuff, it was like metatarsal stress fractures, calcaneal stress fractures, Achilles injuries, calf stuff, and the knee and hip stuff kind of calmed down. But then as you've gone back, like trend wise, injury wise, we're seeing more knee, hip with some Achilles things, but not as much foot and ankle. But that's just because that's where the trends are going. But the how often people get injured, exactly the same.
And to a certain extent, it goes back to what you were just talking about. Energy isn't really created or destroyed, and I might not be using that 100% correctly, but I think we get the point.
Yeah, you're shifting.
There's still impact going through your body.
Yeah, exactly.
It's just where you're placing it and how it's reacting to it.
Yeah. And do you have the ability to moderate that force better at that new spot versus or not? That's what it really comes down to.
Yeah.
So that goes back to, by the way, for all the runners, no shoe is going to absolutely fix your problem. You need to make sure they're great. It's good. They can be helpful. But if you have some kind of impairment, you need to address the impairment. Is that mobility? Is it strength? It more often is with runners. It can very frequently be strength. You gotta take care of that. These are super fun, but you also need to make sure this is one part of the puzzle. It goes back to that whole impairments list that I'm sure you gave the students, right? It's like, it's never that one thing every time. Maybe you might get lucky, but you got to evaluate the whole thing.
Yeah. Well, Matt, we have loved your perspective. Before we let you go, I want to turn it over to you. Is there anything in your clinical experiences, your experiences as a faculty member, your experiences as the starter of Doctors of Running, and just as a consumer of running products and a runner yourself, is there anything that you wish you could educate PTs or the running community about that you feel like they need to know?
Oh my gosh, there's so many things. I guess if I was going to dial it down, I would say one of the most important things is being very aware of the individual. And that means both as a PT as well as a patient or consumer, and going, what works for me is the biggest thing. Like what might work for my neighbor or my running partner or my PT or even us at Doctors Running might be different than what what works for you. So this is a learning opportunity. And so what I really want to encourage is PTs, consumers, learn everything you can. Do not make assumptions, and try to work with, whether it's working with yourself or working with a patient, really try to understand who's in front of you and what their needs are. If you can do that, you're going to be a lot more successful.
Matt, thank you so much. This has been very valuable and so informative and just plain fun. We know that you've got a little one at home. We know you're probably working on about 2 hours of sleep, and most likely it's the at least second week straight of that. So we can't hold you all day. So thank you so much for coming on. Thanks for sharing your wealth of knowledge. And if anyone would like to get in contact with you, I assume send them over to Doctors of Running, or what is the best way to get a hold of you?
Yeah, that's a great question. So obviously Doctors of Running is probably the easiest place, and our email is doctorsofrunning@gmail.com. But we're also on pretty much every social media site you can find. So obviously Instagram, Facebook, I'm gonna be honest, we don't respond as much, just totally out there. But Instagram, YouTube, LinkedIn, I got to give Bach, who's our social media guy, super big credit, because our LinkedIn has taken off, and I did not think that was going to happen. And by the way, for those interested, that's where the entire running industry is. So any of those areas, email, let us know. For any masters runners over 50 that are listening to this with Achilles problems, please contact me via email. I still need people for my study, and I'd really like to get this PhD done. But yeah, any of those places you can find us, and we will do our best to respond. We do get a lot of emails, but we do our best to try to get to everybody.
Well, thank you, Matt, again. And if anyone does have that is listening, if anyone does have a runner that is over 50 and has Achilles issues, please reach out to Matt. We want to make sure he gets that PhD done, and we'll look forward to keeping an eye on Doctors of Running and everything that Matt does. And again, Matt, thanks so much for coming on, and please have a great day, and we'll talk to you soon.
Thank you so much. I appreciate it.
Yeah.